Hello friends, it has been a while since I posted my previous video. I apologize for the delay actually. Today, instead of presenting in the form of slideshow, I just want to briefly talk, a general idea about the parenteral nutrition. When we say parenteral nutrition, it means anything which we are giving by the injection, other than GI tract, other than the gut actually. Uh, Sometimes we got TPN, which stands for total parenteral nutrition, but it's not always that we're giving everything through the injection. Sometimes this patient is getting some food through the tube feeding. So it's not always TPN, not totally parenteral. So most of the time it's partial parenteral nutrition or PPN. There's certain indications for the PPN, TPN, especially patient those who cannot eat, or who cannot we or somehow if we cannot use the GI tract, could be any reason: trauma, surgery, bariatric surgery, cancer, or especially in babies if they have some gastrointestinal abnormalities, where it's not properly developed, or there's like a twined in a certain way, it's not properly. So like gastroschisis on omphalocele, or if the patient has necrotizing enterocolitis, so anything, or if the esophagus is fused with the trachea, any fistulation there. So many reasons, if somehow we can use the gut, or if the patient is those are the patients who are eligible for the parenteral nutrition. Now, before you consider the patient, to start on the TPN, always look at the not only the no, not only the these indication, but also look at the patient status, their volume status. Are they hypovolemic or hypervolemic? Is their heart in good condition? You don't want to overload with too much fluid. How about the lungs? Not too much fluid you don't want to congest the lungs as well. So look at the renal function, because if the renal function is bad, you don't want to give too much amino acid, which can raise the blood urea nitrogen. So consider those factors. And also very important to look at the lab value, especially the electrolytes, because before we start the PPN, make sure all the electrolytes are within the normal range. Let's say if the patient is hypokalemic or hyponatremic, or magnesium is low, calcium is low, try to correct those before you think of starting the patient on TPN. Why? Because TPN itself has its own complication. You don't want to complicate things even more. So look at those factors and look at the calorie requirement. The calorie requirement can change from time to time depending upon the patient condition. If the patient metabolic rate can go high depending upon the acute stage, or it can go down, especially if the patient is intubated, patient is getting a lot of sedating agent, so those patients, the BMR will go down, versus if it's acute like septic shock, or under stress, the BMR, the basal metabolic rate, will go up. So based on the BMR, their energy requirement, calorie requirement will fluctuate too. So in the nutritionist usually calculate the requirement on daily basis. Now, before they start those patients, they evaluate all those patients, especially they think like patient malnourished, and patient we can use the gut for certain time, more than a week or 10 days. They got to be on parenteral nutrition. So they considering all those factors, the dietitian actually evaluates, and then they give their recommendation based upon how many calories, basically. Well, the idea behind the parenteral nutrition is giving the food in the form of injection. Now when we giving this food, we is basically carbohydrate, protein, and the fat, a mixture of all these three. We use dextrose carbohydrate as a major source of energy, and the fat. Now we don't use the amino acid as a source of energy. Amino acid basically just to replace what is the daily body amino acid requirement is, So basically we're using the carbohydrate and the fat as a source of energy, not the amino acid. Amino acid just to keep the enzyme and basically the proteins intact, So now depending upon how much dextrose you're going to give, dextrose 10%, 12%. If it's more than 10%, try to give it via central line. If it's less than 10%, you can give the via peripheral line, because when you look at the dextrose 10% itself and the electrolytes in the TPN, looking at the osmolarity, those two ingredients itself makes the osmolarity somewhere around 800 milliosmol per liter. Peripheral line, we don't want to give more than 1000 milliosmol per liter. At our institute, our hard stop is 1200 milliosmol per liter. We don't want to give, if the osmolarity is more than 1200 milliosmol, we don't want to give via peripheral line, because it can damage the vein, it can cause phlebitis. So well, if it's 1200 or higher, definitely central line. Central line, you can go higher, up to 1800 milliosmol per liter. So first thing is decide calorie requirement. Now in order to give the calorie requirement, you have to give dextrose, so it comes to dextrose 10% or higher. So that will actually, based on that, you decide peripheral or central. If the patient is going to be on TPN for a long period of time, preferably central, not peripheral. So other thing is, when you're using the central line, the couple of different catheters we use, we call PICC line or the central line. Central line does not mean artery. Sometimes, especially in the babies, we say, why umbilical artery. It can be confusing because it's not artery. Remember that it's not artery. It's a vein actually, but it's umbilical artery means because this is the actually the artery which is coming from the baby and going to the placenta. Actually, it's the return which is coming from the baby and going to the placenta. Whereas the umbilical vein is the one which is coming from the mother's placenta and going to the baby. Umbilical vein is supplying the oxygenated blood. So be careful. Umbilical artery is carrying the deoxygenated blood back to the placenta for oxygenation. So if it's umbilical artery, you should be using heparin. Whereas if it's umbilical vein, most of the time we don't use heparin. Like when it's come to heparin, it's 1:1, either 1 unit per ml or 0.5 unit per ml, or sometimes with tiny amount 0.25 units per ml if it's umbilical artery. For umbilical vein, no. Sometimes they do use heparin, but most of the time we don't. So as far as the central line, peripheral line. So based upon the osmolarity, dextrose, we determine central versus peripheral. So central is usually subclavian vein or the internal jugular. Central line means like basically a bigger vein. It is not an artery; it's a bigger vein. So that's the whole idea. Central line means. Sometimes we call, because central line, if you're using central line, be careful, because central line itself can, if a patient catches infection, it's a problem, because when those patients who have the central line, if they get the infection, we have to report it to the health department. Usually I think it's the CMS or the CDC, they monitor those hospitals, and the reimbursement is based upon how many patients got CLABSI, which CLABSI stands for central line associated bacterial infection. So that's one thing they look at, So in most of the time, I mean, instead of using central line, they use midline, where they leave the catheter a little bit away from the um, yeah, away from the aorta, basically. The I mean the atria, with the heart, especially in the baby, you don't want the catheter to go all the way near the atrium, because especially the baby moving hands in, it can rupture the atrium, so they leave the tip a little bit away from the right atrium anyway. So central means a bigger vein, so club-C is a major issue, we don't want the patient to develop infection, So when the dietitian looks at any person who is eligible for the parenteral nutrition, they calculate the calorie based for certain formula. One of them is Harris-Benedict formula. Other one is like some institute, they use indirect calorimetry, which I think is a better way to get better idea how much calorie requirement is there, because patient calorie requirement can change from day to day basis, so in the beginning it could be more, next day it could be less, especially if they are on paralyzed on sedating agent, so BMR will go down. So when you look at the indirect calorimetry, basically it's looking at the production of the CO2, which is metabolic waste from the by burning of the food, actually. So indirectly, the more CO2 I'm exhaling out, that means the more food or more carbohydrate I have burned, actually. So that's an indirect way of calculating how much the energy person is basically using. So we try to replenish the same amount. So the ratio, but when you burn glucose, which is a clean free fuel, glucose molecule, let's say 1 mole of glucose, let's say C6H12O6, when 6 oxygen molecule combine, you producing carbon dioxide, water, and ATP, basically producing 6 molecule of CO2. So the ratio between the CO2 and oxygen is 6 of CO2, 6 oxygen, comes out to be 1. So so indirectly it's telling me I'm burning more of the fat, versus I'm burning more of the carbohydrate. But if I'm burning more of the fat, then this ratio will change. We use carbohydrate as source of energy, and the fat as a source of energy. We don't use the protein or the amino acid as source of energy. Those are basically just to maintain the the nitrogen pool in our body, so because our proteins, whatever protein in our body we have, they are already used up in some form, like enzyme or muscle, or or the tissue, so we don't have any stored protein. We do have some nitrogen pool, which keeps or recycling some of the amino acid, but as such we don't have any stored like protein, just like we don't have any stored ATP. Why we don't have stored ATP? Because the phosphate is highly reactive chemical, so the body don't want to store any dangerous chemical. It's like a fire, like explosion, so when you ignite a matchstick, you see the fire, so the ATP for the phosphate is highly violent chemical, so the body doesn't store it. It's produced only when it's needed. Similarly, we don't have stored oxygen, so we continuously need to breathe. Basically, we have oxygen, we have hemoglobin which is carrying it, we dissolve oxygen anyway. So the TPN, the energy requirement is calculated by the nutritionist, usually anywhere around 25 to 30 kilocalorie per kg. Some patients have a higher requirement, some have little less. Skinny person, usually their calorie requirement is more, because they dissipate more heat from the body surface area as compared to from a chubby person, So, uh, so when they calculate the energy requirement, they don't give the 100% of the energy requirement from day one. There's something called refeeding syndrome. What a refeeding syndrome is, basically, if somebody is malnourished or haven't eaten properly for quite some time, you don't want to feed them all of a sudden. You don't give them full, meal all of a sudden. Why? Because when eating food, the body is going to, especially carbohydrate, body is going to release insulin. Insulin is a anabolic hormone. What it means is going to push things inside the cell. Why inside the cell? Because you want to build up, it's an anabolic hormone. You want to build up new tissue, new structure, So especially in the baby, for example, while the mother is pregnant, some ladies, they develop gestational diabetes. Why? Because more sugar means more insulin, and it's big because baby needs more insulin. Baby is developing, baby needs to develop more, so mother nature actually exposes the baby to more glucose, which means indirectly producing more insulin. You want to build up the tissue, baby's tissue, so basically it's good for the baby, whereas it could be bad for the mother, though. So gestational diabetes is a kind of, it's not a must though, but some ladies get it. But high amount of glucose is needed for the baby, actually, to build up the baby. So the same logic applies in the refeeding syndrome, because when you're eating carbohydrate, body releases insulin. So it pushes the potassium phosphate, especially potassium phosphate, inside the cell along with the other ingredients. So what happens, the potassium falls. If the potassium falls, you're going to affect your heart. So you don't want to create unnecessary problem with the heart. Why want to create another, like arrhythmias, So and so that's one. When you look at the lab, actually, especially the lab, always pay attention to potassium phosphate, especially the second day, or third day. If it's falling, that means look at the dextrose you're giving. First day, normally don't start dextrose 10%. Normally we start around somewhere around 7%, 6 to 7%. Next day onward, yes, you can give the dextrose 10%. So when you looking at the osmolarity, so dextrose 10% itself is about, and plus electrolyte itself is about 800 milliosmol. So peripherally, we don't want to give more than 1000 milliosmol because of the phlebitis can damage the vein, whereas centrally you can go higher up to 1000 milliosmol. So the different indication in baby, different indication in adults, depending upon it. In babies, those babies are premature, less than 35 weeks, less than 1500 gram. And they have, the GI is not properly developed. There could be some anatomical, I will say, developmental delays, or structural delays, abnormalities like omphalocele, gastroschisis, or if the patient has a necrotizing necrotizing colitis, or in any reason you can use the gut. Those are the patient eligible for the parenteral nutrition. So certain things you need to keep an eye is on the important is refeeding syndrome. Other one is the GIR, something called glucose infusion rate. What it stands for is how fast you're giving the glucose, basically, or how fast the body is burning the glucose. This is more important, especially the way I look at it. The more faster you give glucose, the body prefers glucose because it's a quick source of, is a clean source of energy. So if you're giving glucose much faster, means producing more CO2 much faster. So that can put a burden on the lungs, especially if the patient is COPD or having lung issue. The more CO2 means the lung have to work more to exhale it out. So I mean, in babies, like GIR is the glucose infusion rate is more because of their development, because they need more glucose for the body development. Whereas for adults, we don't want the GIR to go higher than 7, actually, not higher than 6, because if you're giving glucose higher than, if the GIR is more than 7 in adults, is not doing any benefit, but is causing hyperglycemia. The other idea behind glucose infusion rate is to maintain constant supply of the dextrose, so that we don't want the amino acid to be burned as a source of energy. We give energy in the form of carbohydrate and the fat, but not the amino acid. Amino acid just to replace, to maintain the nitrogen pool. So the GR is indirectly telling you you're giving enough to spare the amino acid for to be used as a source of energy. So those things you need to be familiar with a little bit. As far as the when it comes to mixing, as far as mixing the ingredients, putting the electrolytes in the in the machine, the order doesn't match as long as you're keeping the calcium and the phosphate uh, apart from each other as much as possible. What I mean, if you're adding the calcium in the beginning, do the phosphate at the end, or the vice versa. Try to look at the logic behind our body is doing. For example, in our body, if the calcium is going up, phosphate has to go down, or vice versa. Why? Because if in my blood, if both the calcium and the phosphate go high at the same time, they will precipitate. They will form crystal. Look at my bones. My bones is nothing but the cartilage plus calcium phosphate deposited into that. So if I'm looking my nose, my ear, the cartilage is basically the collagen, or without the calcium phosphate. So if I put deposit calcium phosphate, it will become a bone. So if you have too much calcium phosphate coming together, all you're making is think as if you're making bone inside the blood circulation. You don't want problem. So Mother Nature actually find a beautiful way. If the calcium goes up, phosphates go down, except in the bones, where Mother Nature is keeping calcium phosphate and keep them together and give you like a structural support. So certain things you need to be familiar, basic idea you should be aware of, actually. Did I mention about indirect calorimeter? Indirect calorimeter is actually other way to find out calorie requirement. Basically, look at the how much CO2 person is producing. So that way I can calculate how much the person is consuming or using the energy, because as I said, like the energy requirement can vary from day-to-day basis. Not every institute uses indirect calorimeter, maybe only few institutes, bigger hospital, teaching hospital. Not every hospital has the indirect calorimeter, I will say, tools to utilize that technology. Okay, all right. I think when it comes to details, I might have to give it as a slideshow. So I think this was my general idea about the TPN. If anything left over, I'll try to cover up in my next post. Thank you.